Thanks very much, Simone. It's a real pleasure to speak to you this afternoon. So thank you. I'm going to describe some of our more recent work on the ethics of cluster randomized trials. Particularly, I'm going to focus on the issue of informed consent, because I think that's presented substantial challenges for researchers and research ethics committees. In the approach I'm going to outline, 3 questions need to be answered to determine whether informed consent must be obtained from people in a cluster trial. First, are the individuals research participants? Second, if they're research participants, to what study elements are they exposed? And third, do conditions for a waiver of consent obtain for each study element? So I'm going to consider 3 examples: a cluster trial of a cluster level intervention, one of a professional level intervention, and one of an individual level intervention. And I think, the interesting thing that comes out of this way of analyzing it is the fact that issues of consent don't vary with the unit of randomization. Rather, they vary with the unit of intervention. Okay, so some introduction. Unlike individually randomized trials, or I'll sometimes call these patient randomized trials, cluster trials randomize intact social groups. Cluster trials are complex and multi-leveled, so that in one study, hospitals may be randomized, health providers intervened upon, and data collected from patients, often by accessing electronic health records. So this is our representation then of a cluster randomized trial. Cluster trials have become increasingly popular over the last 20 years. We've seen a near exponential growth in the number of reported trials. Of course, cluster trials are a family of designs, and these designs include parallel arm before and after, cluster crossover, and stepped wedge designs. When it's a cluster level or professional level intervention that's being evaluated, a cluster trial is the only randomized alternative to evaluate those interventions, right? So an individually randomized trial obviously isn't possible. But for individual level interventions, an individually randomized design is, at least in theory, possible. So why might one choose a cluster randomized design? Well, there are a number of reasons. Cluster trials have advantages. All patients in a cluster are treated the same. And that means that perhaps one needs less research infrastructure within each center. It might further seek to promote adherence and to prevent contamination. So these are substantial advantages conferred by cluster randomization. Perhaps less well appreciated, though, are the disadvantages of adopting a cluster randomized design. Of course, cluster designs require larger sample sizes compared with individually randomized alternatives. There are higher risks of bias. There are usually higher risks of baseline imbalances. The analysis is more complicated. Attrition is potentially more serious. And of particular relevance to our talk this afternoon, the research ethics of these trials is more complicated. So why do I say that? Why do cluster trials pose more difficult ethical issues? Well, I think the answer to this question is that cluster randomized trials raise difficult ethical issues because of their design. Fundamentally, they involve groups rather than mere individuals, and the moral status of groups is just less clear than the moral status of individuals. As I've described, these are complex studies, and we've already seen how one study may randomize hospitals, intervene upon physicians, and collect data from patients. And that means it can be difficult to figure out just who should count as a research participant in any particular study. Further, the intervention may itself occur at different levels, including the cluster, the professional, and the individual, making it sort of complicated to figure out from whom should informed consent be sought and for what. And finally, most research ethics guidelines were written with patient randomized trials in mind. And as a result, applying ethical guidelines to cluster trials is fraught. There is help, though. The Ottawa Statement on the Ethical Design and Conduct of Cluster Randomized Trials is the first international ethics guidance specific to cluster randomized trials. And since its publication in 2012, just a little under 10 years ago, the document has had a large impact, I think, on the way that cluster randomized trials are designed and reported. And it's also had an impact on ethics policy internationally. So the 2016 revision of the CIOM's International Ethical Guidelines substantially adopted many aspects of the document in the novel Guideline 21, I think it is. The Ottawa Statement encompasses 15 recommendations covering 7 ethical domains. But of all of these domains, I think informed consent just remains particularly perplexing. And the reasons for that are several, but part of it is just that the identification of research participants, as I've said, can be quite complicated in cluster trials. And that, of course, complicates questions of from whom informed consent is required. But that's not the only thing going on here. I think part of what's going on, to be frank, is a common misconception that the use of cluster randomization itself may justify not obtaining informed consent. And I think that actually this is just sort of not right. So we need a more nuanced view than this, and that's what I'm going to try and provide in this talk. So what does the Ottawa Statement say? First, it defines a research participant broadly. It says a participant is an individual whose interests may be affected as a result of study interventions or data collection procedures. Okay, well, that's a pretty broad definition. There are a number of criteria that follow this broad definition. So research participants are those to whom the study intervention or control is delivered, or those who are interacted with by researchers for research purposes, or those whose private health information is collected. There's a presumption, of course, that the informed consent of research participants is required. Because of the complexity of cluster trials, differing people in the same trial may be exposed to different study elements. These elements may include enrollment, study interventions, and data collection. So a useful heuristic in cluster trials is get consent where you can. When health providers are research participants, their informed consent is generally also required, and we'll talk about this specifically in one of our examples. Finally, there may be circumstances in which a research ethics committee may approve a waiver of consent. Key criteria for a waiver of consent are infeasibility and minimal risk. Infeasibility refers to circumstances where the study could not be conducted with informed consent. And minimal risk refers to circumstances where the potential harms of study participation are comparable with those of the daily lives of the study population. A research ethics committee, it's important to note, may grant a waiver of consent for one aspect of a study, for instance, the study intervention, but not another, such as data collection. So informed consent may nonetheless be required for data collection. So how to navigate this? We propose a three-step approach to address the need for informed consent in any particular case. The first question is, who are the research participants? Second, to what study elements are they exposed? And third, for each study element, is a waiver of consent appropriate? So this is the three-step approach that we're going to apply to each of the three examples that we consider this afternoon. When this approach is applied, it's interesting that informed consent issues actually tend to sort out by the study's unit of intervention. So broadly speaking, we see one set of issues for cluster-cluster trials, another for professional cluster trials, and yet another for individual cluster trials. So let's go through an example of each of these and see if we can not only talk about the particular features of each example, but also draw some general lessons for each of these broad types of cluster randomized trials. So our first example is the Devon Active Village Evaluation Trial, or the DAVE trial, which sought to evaluate a cluster level evaluation intervention. So the DAVE trial asks, does a community level physical activity intervention increase activity levels in rural communities? The intervention itself was a community tailored intervention offering different types of physical activity opportunities for all age groups in the community, and it was provided for 12 weeks with some follow-on support to continue the intervention in the community. The primary outcome was the proportion of adults reporting sufficient physical activity to meet internationally recognized guidelines measured by postal survey. The design was a step wedge cluster randomized trial in which the intervention was rolled out across 128 rural villages in 4 steps. So let's think about the DAVE trial here. Who are the research participants? Is it just those members of the community who in fact ended up participating in one of the sporting events? I think the answer to this question is actually no, it isn't just them. The study intervention involves organizing and advertising community sporting events, including advertisements in local media, newspaper, radio, newsletters, as well as posters in local sports centers and village halls. The intervention was designed, yes, to impact community members directly through participation in sporting events, but importantly, it was also designed to impact people indirectly through changing beliefs and attitudes in the community about the need for regular exercise. Therefore, I think that all community members were research participants in the DAVE trial. Well, so to what study elements were people exposed? Well, as we just described, all community members were exposed to the study intervention. And additionally, a random sample of 50 households, I think in each step, did receive a postal survey on physical activity. For each study element, is a waiver of consent appropriate? The study intervention is delivered to entire communities. Getting informed consent from every member of a rural community comprising 500 to 2,000 people would, I think, plainly be infeasible. And further, refusal of consent would be effectively meaningless anyway, as it would be difficult, if not impossible, to avoid all aspects of the study intervention. The study exposed community members to advertisements in the same way that they're exposed to advertising in their daily lives. And furthermore, community members were free to participate in scheduled events or not. And so in sum, we believe the study intervention posed only minimal risk, and therefore a waiver of consent is appropriate for the study intervention. What about data collection? Well, here we come to a different conclusion, I think, because it's feasible to obtain the informed consent of participants for postal surveys, brief written consent, and therefore consent ought to have been obtained for data collection. So those are the specifics of the data trial. What more general lessons might we draw here about cluster trials evaluating cluster level interventions? Well, cluster level interventions are of course delivered to the community, hospital, or social group as a whole and can't be avoided by individual cluster members. When cluster members can't avoid exposure to the intervention, refusal of consent becomes effectively meaningless. So the use of a waiver of consent for cluster level interventions is appropriate provided the intervention poses only minimal risk. Generally, when data collection occurs at the individual level, informed consent for data collection may be required. All right, let's get on to our next example. The CARDS trial evaluates a professional level intervention. So the objective in the CARDS trial was to address the question, can an online audit and feedback system improve cardiac rehabilitation teams' concordance with clinical guidelines, and can it improve patient outcomes? The intervention here was audit and feedback, and in brief, healthcare professionals uploaded de-identified patient data to the CARDS online system, which creates a feedback report. There were educational sessions with the cardiac rehabilitation teams to review these feedback reports, and health professionals had an opportunity to create and implement quality improvement action plans. The primary outcomes in the CARDS trial were the proportion of care processes completed by the healthcare team and the proportion of patients who obtained pre-specified clinical outcomes. The design of the CARDS trial was a parallel arm cluster trial involving 18 cardiac rehabilitation centers. So our first question, who are the research participants? Well, the audit and feedback intervention was delivered to the team of healthcare professionals as a whole, and therefore health providers are research participants. Let me say that again, health providers are first and foremost the research participants in the CARDS trial. Now I repeat that because in our experience, researchers and research ethics committees commonly miss the fact that health providers may be research participants, particularly in knowledge translation and health services research. It may or may not be the case that the patients of those health providers are research participants. Indeed, when the study intervention is delivered to health providers to promote the uptake of evidence-based care, their patients are not automatically research participants. In this case, though, patient health data is collected, and therefore the patients in the CARDS trial are research participants in this regard. So to what study elements are they exposed? Well, we've already kind of hinted at this. The health providers themselves are exposed to the audit and feedback interventions, including written reports, education sessions, and involvement in the creation and implementation of action plans. Patient data, on the other hand, is collected, de-identified, and so on. So for each study element, is a waiver of consent appropriate? While health provider consent is often straightforward, so it's often the case that the consent of a health provider is required in a professional cluster trial. In this case, it ends up being a little more complicated because the intervention is delivered to an interdisciplinary team as a whole. So the intervention included developing action plans to improve the quality of care provided by the team, and each cardiac rehabilitation team member was able to assign action plan items to any other team member. So consequently, in this case, I think the study could not have been conducted with health provider consent because refusal of consent from health providers would be effectively meaningless. Further, the study intervention involved activities consistent with the daily lives of health providers and posed, I think, minimal risk. Thus, a waiver of consent is appropriate for health providers in this study. However, informed consent for data collection from patients is, in this case, feasible, and therefore their informed consent is required. Okay, that's the CARDS trial. What are some messages that we might pull out of this for professional cluster trials more broadly? Well, professional level interventions are delivered to health providers, and therefore it's health providers first and foremost who are research participants in professional cluster trials. And when health providers are research participants, their informed consent should be obtained unless there's a clear justification for a waiver of consent. Patients in professional cluster trials are not research participants unless they're the recipient of the study intervention, they're interacted with for research purposes, or their private health information is used. Patient collection may be required, patient consent rather, may be required for individual level data collection. So let's move on now to our third example. The third example is the Prevention of Infections in Cardiac Surgery trial, or the PICS trial, that evaluated an individual level intervention. So the PICS trial evaluated the feasibility of a cluster randomized design for a definitive trial to evaluate the optimal duration and choice of perioperative antibiotic prophylaxis for patients undergoing open heart cardiac surgery. The intervention was single dose cefazolin versus a combination dose of cefazolin and vancomycin in both short-term and long-term administration. So there were 4 different interventions here. The primary outcomes included feasibility outcomes of the proportion of patients receiving the assigned treatment, the proportion completing follow-up assessments, and a third outcome, which I take it was to be the primary outcome for the definitive trial, the incidence of sternal surgical site infections. The design was a factorial cluster crossover pilot study. Okay, so let's think through this example. Our first question, of course, is who are the research participants? Well, actually, that ends up being incredibly straightforward here. Because the identification of research participants in patient randomized trials and cluster randomized trials of individual level interventions is very similar, because it's the same individual, commonly a patient, who's exposed to the study intervention and data collection procedures, right? So individual cluster trials are the most like patient randomized trials, and they're the most like them in terms of the ethics of this design. So in the PICS trial, patients are research participants because they're the recipient of the study intervention, and they're interacted with by researchers for the purposes of data collection. So to what study elements are they exposed? Well, as I've sort of said, this case ends up being very, very straightforward because it's so much like a patient randomized trial. So patients here are the recipients of the study intervention, cefazolin or cefazolin plus vancomycin, for a short period of time or a long period of time. Routinely collected health data was also obtained from patients, and they were additionally interviewed by phone 90 days after surgery. So for each of these study interventions, was a waiver of consent appropriate? Well, it turns out that considerations of informed consent are very, very similar in individual cluster trials compared with patient randomized trials. Patient randomized trials rarely meet the conditions for a waiver of consent. And the same is true for cluster trials of individual level interventions. Generally speaking, the administration of an individual level intervention involves an encounter between the health professional and the patient. And consequently, it's typically feasible to ask for informed consent for both the study intervention and data collection at that time. So that's the PICS trial. What broader messages, what might we draw here for individual cluster trials in general? Well, considerations of informed consent are similar in individually randomized trials or patient randomized trials and cluster trials of individual level interventions, just because they test the same kinds of interventions. If an intervention would not qualify for a waiver of consent in a patient randomized trial, generally speaking, the intervention should not receive a waiver of consent in a cluster trial. And certainly, if consent would be sought for an intervention in clinical practice, as with a drug or a vaccine, a waiver of consent is just not appropriate. Okay, I'd like to spend a few minutes to just talk a little bit more about the issues here illustrated in individual cluster trials. And the reason for this is this is probably the most contentious bit of my talk and the most, the area of liveliest debate in the literature. So let's dig a little deeper here, and I'd like to consider how commonly do individual cluster trials use a waiver of consent? Well, the answer is perhaps more commonly than you would think, and perhaps more commonly than should be the case. So, led by my colleague, Monica Talliard, in 2020, we published a review of a random sample of 40 cluster randomized trials evaluating individual level health interventions. We looked at a number of things, including consent for the study intervention. And we found that in 23 out of 40 of these individual cluster trials, it was reported that informed consent was obtained for the study intervention. 21 of these used written informed consent, and 2 of these used verbal informed consent. But in 8 of 40 trials, there was a reported use of a waiver of consent. And in a further 9 of 40 trials, consent for the intervention was either not mentioned at all, or it was unclear just what had happened in the study. Justifications for waivers of consent were reported in 6 of the 8 trials that said they used a waiver. And so this is a very interesting set of trials to us. And we sort of took a close look at the 6 trials that reported a justification for a waiver of consent. What was so very interesting about these 6 trials was that only 1 out of the 6 provided a justification that was consistent with international ethics guidelines by stating simply, all that it needed to state was the following: that the study constitutes no more than minimal risk, and that consent could not be, that the research could not be carried out without a waiver of consent. That's all that the study needed to say, and only 1 out of 6 actually said that. So that leaves us with a really interesting question: is what did the other 5 trials say? And how is it that a research ethics committee approved the use of a waiver of consent based on these sort of other reasons? So what were the other reasons? there were a number, but the most commonly stated were the following. First, that the individual level intervention is covered by a single policy for all patients. So for instance, if it was hospitals that were randomized, each of the hospitals had a single, for instance, treatment policy covering all patients of a particular type. The second reason was that obtaining written informed consent is too expensive. The third is that requiring informed consent is likely to result in selection bias. And the fourth is that consent will undermine the pragmatic ends of the trial. So this is really interesting, I think, because even though these reasons are extra regulatory, these aren't sort of criteria for a waiver of consent that you'll find in research ethics guidelines. Nonetheless, some research ethics committees, it seems, were convinced by these reasons. So what's going on here exactly? Well, I think part of the explanation may be that at this moment in history, that the importance of informed consent is not being fully appreciated by all researchers or research ethics committees. There's a very nice paper talking about this phenomenon by the legal scholar Alexander Morgan Capron. This was a paper published 4 years ago in the Journal of Medical Ethics. I think it's a terrific read, and I would certainly recommend that you have a look at it. And Alex Capron argues that in an era of learning health systems, informed consent in research is in fact imperiled. He says, taking a broad view of informed consent will be important to the preservation of its core value. Today, biomedical research is becoming ever more closely integrated into the ordinary clinical activities of hospitals and physicians' offices. That shift can be expected to erode consent if we're not careful. A very nice feature of Capron's article is the fact that he articulates 3 separate foundations for consent in research. Of course, one of those foundations is requirements found in research ethics guidelines. But importantly, there are other independent foundations for the consent requirement in research. One is the common law principle that we have a legal right of privacy, and that's an important historical and intellectual foundation of the consent requirement in research. And also, all of us have a human right to be free of experimentation without our informed consent. So, with the importance of informed consent squarely in mind, let's circle back and have a look at these 4 justifications that have been articulated for the use of a waiver of consent. What can be said of these considerations? So let's start by considering the justification that treatment is articulated in say a hospital-wide policy or something like that. Invoking a hospital-wide treatment policy is plainly designed to make the study intervention here sound like a cluster level intervention. And one of the key innovations of the Ottawa Statement was its relatively permissive stance with regard to the use of a waiver of consent for cluster level interventions. But what is a true cluster level intervention? Eldridge and colleagues define a cluster level intervention as one delivered to the cluster, but that is also indivisible at the level of the individual. So the intervention in the Dave trial, I think, is a good example of a cluster level intervention. But the intervention, say, in the PICS trial would not be an example of a cluster level intervention. It's obviously an individual level intervention. Why do I say that? Well, it's because that even if the antibiotic regimes in the PICS trial, I'm just saying for instance here, were implemented as a hospital-wide treatment policy, of course that policy would contain medical exceptions for patients. If a patient had an allergy to cefazolin, even though there was a hospital-wide treatment policy that patients should receive cefazolin, that patient, of course, would be exempted from that policy. And so, like a medical contraindication, a patient's refusal of research participation should exclude her from the study. Even if implemented as policies, drug interventions, antibiotic interventions are in fact, treatment interventions are in fact individual level interventions and need to be treated as such. What about cost? Cost is, of course, another factor. Informed consent just increases the cost of every randomized controlled trial. I think it's fair to say, right? So we need to be careful about invoking justifications that would sort of allow us to eliminate consent, say, in all randomized trials. So we might say, well, what is it in particular about a cluster randomized trial that's making consent so very expensive? Well, I think one thing we need to think about here is the fact that cluster randomized trials require larger sample sizes than patient randomized trials, and sometimes they require much larger sample sizes. So in a justification for a waiver of consent that's considering the feasibility of doing the study, researchers should not only present to the Research Ethics Committee cost estimates associated with obtaining informed consent versus not obtaining informed consent using a cluster randomized design. They should also provide cost estimates for conducting the trial as a patient randomized trial in which informed consent is sought. And because that trial is quite likely to be a good deal smaller, it may be that design is in fact feasible from a cost perspective. Of course, there are other ways of reducing costs in cluster randomized trials. Perhaps each center doesn't need a research coordinator. Perhaps informed consent can be obtained by health providers themselves. So selection bias is the third reason that was proffered for the use of a waiver of consent. And of course, it's a very serious concern in cluster randomized trials. It's sort of a neat solution to selection bias if you just sort of say, well, we're just going to sort of eliminate recruitment. Everybody's in the trial, so we don't have selection bias. So from a purely sort of methodological standpoint, I suppose that sounds pretty appealing, but we need to weigh this against the ethical significance of informed consent and respecting the autonomy of all of those prospective participants. So there are other ways that can be invoked here to address selection bias. If possible, eligible participants should be identified and recruited prior to the randomization of clusters, and that's going to very substantially mitigate concerns about selection bias. And if this isn't possible, then recruitment should be carried out by study personnel or staff who are unaware of the cluster's allocation. And crucially, the same information should be provided to prospective participants regardless of the cluster to which they've been allocated. So this is a very substantial challenge for cluster randomized trials, but there are steps that can be taken short of the use of a waiver of consent to address selection bias. My point here is that researchers and research ethics committees should very carefully consider these alternatives before suggesting that a waiver of consent may be appropriate. The final reason I want to consider is pragmatism. And certainly over the last 10 years, there's been a big push towards doing trials that are more pragmatic. And that's a really, really important thing. It's important for informing patients. It's important for informing medics. It's important for informing health systems as a whole. It's interesting, though, to see a push towards the use of a waiver of informed consent based on claims of pragmatism. My sense is that part of what's going on here is in fact a false dichotomy. A false dichotomy between, on the one hand, sort of the rigorous standard requirements for written informed consent administered by a research coordinator on the one hand, and a waiver of informed consent on the other hand. I think in many cases, what's happening is that researchers and then perhaps research ethics committees are going, gosh, in this really pragmatic trial, standard written informed consent just doesn't seem appropriate for this primary care setting. So therefore, let's just use a waiver of consent. But that's a false dichotomy, because that thinking ignores middle ground pragmatic approaches to informed consent that I think are more appropriate to the sorts of settings where pragmatic trials are conducted, including primary care settings. And these pragmatic approaches include electronic consent, in which patients may be educated and provide consent using a tablet. Short form consent, in which a one-page consent form is used. And integrated consent, in which the health provider obtains consent for research participation verbally and documents it in the electronic health record. So I think researchers and research ethics committees need to become more aware of this sort of false dichotomy, and I'd very much like to see an expansion in the use of these middle ground pragmatic approaches to informed consent. So there we are. Well, informed consent issues in cluster randomized trials are perplexing indeed. It's my hope that our three-step approach provides some useful guidance. And contrary to what may be thought, consent issues, and I hope I've made this plain, are not a function of the unit of randomization. No, they're not. Rather, they're a function of the unit of intervention. I'm deeply grateful to my co-authors on this paper, some of whom have joined us this afternoon: Hayden Nix, Corey Goldstein, Jamie Brahout, David Forster, and of course, my good friend and colleague, Monica Talliard. Thanks very much.